This is how cataract surgery goes when it's easy. So we see here the pupil is nicely dilated. This is through the microscope camera. Now I'm going to make an incision through the cornea into the front chamber of the eye. It's about 1.5 millimeters. We call this a side port incision, used for, as you'll see, injection or introducing a manipulative tool into the anterior chamber. Now this is a syringe with a cannula, and I'm injecting what's called a viscoelastic. It's kind of a thick, gooey substance, and what that will do is it will maintain the space inside the front part of the eye. That now that there's an opening, it'll keep that space from collapsing. Now I'm going to use a special blade to create another opening in the cornea. This is an instrument called a keratome. It's 3.5 millimeter wide, and it is calibrated to fit the phacoemulsification instrument that I will introduce through that incision. Now I'm making a tear in the anterior capsule that surrounds the lens of the eye. Think of it kind of like skin on a grape. So I'm making a tear here. And then I'm going to make an opening so that I can have access to the lens material inside the capsule. I've made a small tear. I'm going to grab the edge of it and carefully pull it in a circular, tear it in a circular fashion. You can see the edge. And bring that around 360 degrees. And then remove the piece of capsule that I've just cut out. You'll notice the numbers on the sides of the screen. That's data from the instrument showing me the power of the tool as it vibrates, the amount of fluid entering the eye, and the pressure of the instrument that is suctioning it out of the eye. So I use this data to review later. Now this instrument is going to inject saline fluid to separate the hard central part of the lens, the nucleus, from the softer material surrounding it, because it makes it easier to remove the hard material in the center. The main point with the phacoemulsification tip is it has to be sharp enough to cut this hard material and remove it, but if it touches anything else, it will also tear or destroy it. For instance, the iris of the eye, or the material surrounding the hard central nucleus. So this is a phacoemulsification tip, and at the moment you'll see nothing's going on. You'll get the power in the upper left hand corner that's 0. So I'm just using it to push this hard central nucleus around. I'm removing some of the soft material, and now I've started to emulsify, fragment the hard central part of the nucleus. What I'm doing here is making a groove in that material, and I'm going to subdivide the hard nucleus into pieces to make it easier to remove them. So I make this groove, this channel, and you'll see then I rotate it and make another groove. So this is going to allow me to force apart these sections so that basically I have 4 pieces of the nucleus. So the trick here is to avoid touching this cutting tip to anything else other than the hard nuclear material. So we're much less than a millimeter away from the softer cortex that surrounds the nucleus. And we don't want to hit that with a cutting tip. It can be removed just with suction, as we'll see. Now, I introduce this instrument through the side port and manually pull the pieces of the hard nucleus apart. You can see it splitting there. Now I'm going to use the suction, grab it with the cutting tip, and if you look at the upper left corner, I'll apply power to the phacoemulsification tip. What that tip is doing, it's sharp. In the center it has a suction area. You see the white plastic on the outside of it, that's introducing fluid, irrigation, at the same time that the suction is being applied. So that keeps kind of a balance of fluid again, so the structures don't collapse in the anterior chamber. The cutting tip is oscillating at a very high frequency back and forth. You can't really see that, but it's an ultrasonically driven tip that moves back and forth to with a sharp edge to cut the hard nucleus material. So it's using very little power now. Okay, and we've changed the settings on the machine so that it's not going to cut. It's just going to use suction to suction out this softer cortical material that was around that hard nucleus. So you can see that I'm pulling it forward to keep it away from the capsule that remains in the back part of the capsule, pulling it up through the opening that we made at the beginning. Now you'll see I've changed to a different tip. It doesn't have the cutting edge on it, just for suction, and it's also angled so that I can get up into the kind of into the corners here and get that cortical material out. So the capsule, as I say, kind of like skin on the grape, um, is very thin and fragile. So that's one of the main problems that can come up is it can tear, and the material from the back part of the eye comes forward, which is a problem. So now all the cortical material has been removed, and what that leaves is a more or less a bag of the capsule that remains. So what I'm doing is using the viscoelastic again to inflate the bag, create space in there, and we'll see in a minute why that is. Okay, that's the artificial lens, which is soft plastic, so it can be folded. And so I'm putting it into this special device that will hold the folded lens. And then I'll mount that folded lens on a device that's going to push the lens into that bag that we made in the capsule. So it goes in through the same incision that the phacoemulsification tip went in through. It's designed to be the same size. So it goes into the capsule and unfolds itself. And then I'll go in with a special instrument to center it and help those are called haptics, the kind of spring pieces on the edge that hold the optic of the intraocular lens in place. You can see it expanding into the corners of the capsule bag. So it's fairly nicely centered. What I'm doing now is I'm injecting some medication that is going to make the pupil contract, and you'll see that the pupil's getting smaller. It's coming down around the edges of the lens implant. So I'll let that take effect for a few seconds. And then I'll suction out the remaining viscoelastic with the suction tip. We don't want to leave it in the eye because it can cause problems with fluid pressure, with the fluid drainage that naturally happens in the front part of the eye. So we remove the viscoelastic. And that's how it works.